This is part 2 of the lecture covering cerebrovascular accidents, covering stroke diagnostics and treatment for both ischemic and hemorrhagic strokes. One of the first tests usually done for a patient with stroke symptoms is a CAT scan of the head. At first, the CAT scan is usually done without contrast. This is because timing can be an issue in the diagnosis of a stroke, especially with ischemic strokes, as we'll talk about later on in the treatment protocols for fibrinolytics. So they'll begin with that CT without contrast to see if they can find evidence of a stroke, and then they can move forward later on to do a CAT scan with contrast if needed. The CAT scan can show bleeding in the brain, it can show damage to the brain cells, and it can give physicians valuable information about the cause of the stroke, the location, and the extent of the brain injury. As I mentioned already, they may even use serial CAT scans to assess the effectiveness of their treatment and to evaluate the patient's recovery on down the road. CT angiography is another option that might be used in a stroke diagnosis protocol. This provides visualization of the cerebral blood vessels. They inject a contrast dye into a vein, and then images are taken of the blood vessels to look for abnormalities such as an aneurysm. This particular test can also provide estimates of perfusion, and it can detect any filling defects in the cerebral arteries, so any trouble they have with filling of blood. The MRI can detect some vascular lesions and blockages. The image produced by an MRI is sharper and more detailed than a CAT scan, so oftentimes MRIs can be used as an additional measure to diagnose small, deep injuries. The carotid duplex studies are ultrasounds that can be done to determine how well the blood is flowing through the carotid arteries. So that may be, again, another additional diagnostic tool that is used in getting the full picture of the patient who's presenting with a stroke. Transcranial Doppler is also another approach that they can take. This is another ultrasound measurement to measure the velocity of the blood flow throughout the major cerebral arteries. The benefit here is that it can detect microemboli and vasospasms of the cerebral blood vessels. Some additional imaging or tests that might be included would be possibly cardiac imaging, because many strokes are caused by blood clots coming from the heart. They may do angiography to identify if there is any type of cerebrovascular occlusion, any type of atherosclerotic plaque or malformation of the vessels. Lumbar puncture is something that might be included in the diagnostic workup. This is just going to be done to look for any evidence of red blood cells in the cerebral spinal fluid if a subarachnoid hemorrhage is suspected, but the CT is not showing the hemorrhage. So they might include that. That's not necessarily an automatic inclusion in the stroke diagnostics. The Lycox catheter is another tool used in the overall diagnostic process of the stroke. This is used to evaluate the progression of the stroke or the progression of the damage. In patients who have sustained a traumatic brain injury, we might use this, or in patients with a known cerebrovascular accident or a CVA. The Lycox system can provide early warnings of a hypoxic event. And the benefit here is that it allows more time for intervention to restore adequate oxygen delivery to the brain. These are used for usually about 5 days following the CVA. When it comes to the treatment of the patient with an ischemic stroke, the overall goal in the acute management of these patients is to stabilize them and complete their initial evaluation and assessment, including all of their imaging and laboratory studies, within 60 minutes of their arrival to the healthcare facility. Our primary focus is going to be on their ABCs, so their airway, breathing, and circulation. If needed, we would apply oxygen to maintain an SpO2 greater than or equal to 94%. It's possible that patients may have difficulty keeping an open airway because of a decreased level of consciousness, or possibly because of decreased or absent gag and swallowing reflexes. If needed, we would administer the supplemental oxygen, possibly even insert an artificial airway, intubate the patient, or apply mechanical ventilation in order to maintain those appropriate O2 sats and that open airway. Adequate fluid intake in the acute care stage is also going to be critical for them. This can be done via oral fluids, intravenous fluids, or tube feedings. This is a priority, so however it's safe to administer the hydration to the patient, that's what we want to do. We will also want to monitor their urine output carefully to make sure that they do not become dehydrated. Actual decisions regarding individualized fluid and electrolyte replacement therapy need to be done based on the extent of any intracranial edema, any symptoms of increased intracranial pressure, those lab values for those electrolytes, and the patient's INO. We do have to be concerned about the risk for overhydration because this can compromise perfusion. It can increase cerebral edema. If we increase the cerebral edema in the individual, this can lead to increased intracranial pressure. Increased intracranial pressure from the cerebral edema usually peaks about 72 hours after the initial onset of the stroke. Problems with increased intracranial pressure are more likely to occur with our hemorrhagic strokes, but they can occur as well with our ischemic strokes. We also want to make sure in the acute care phase that we do, as soon as possible, get a baseline neuro assessment on the patient. This is going to include administering the NIH stroke scale assessment to the patient. The NIH stroke scale is a method for quickly assessing the severity of a stroke that is experienced by a patient, as well as it helps to determine the appropriate treatment, and it helps to predict patient outcomes in regards to the stroke. The NIH stroke scale is made up of 11 different elements that evaluate specific abilities. It covers elements such as level of consciousness, visual field, motor, sensory, and speech elements. The score for each ability is a number between 0 and 4, 0 being normal functioning of that particular element, and 4 being completely impaired in regards to that particular element. The patient's NIH stroke scale score is calculated by adding the number from each element of the scale. 42 is the highest possible score that an individual can get. And in the NIH stroke scale, the higher the score, that equates to the larger the stroke and the more impaired the stroke patient is. As a general rule, a score over 16 can predict a strong probability of patient death, while a score of 6 or lower actually indicates a strong possibility for a good recovery in the stroke patient. The classifications for the different levels with the NIH stroke scale are a 1 to 4 equates to a minor stroke. Between 5 and 15 is considered to be a moderate stroke. 16 to 20 is considered to be a moderate to severe stroke. And anywhere from 21 to 42 is classified as a severe stroke. It's also important to keep a good history of the patient's, the stroke patient's NIH stroke scale score, because it allows healthcare professionals to monitor the progress, they can tailor their treatment, and they can quantify the patient's improvement or decline over a period of time. Additional treatments of the stroke patient would include regular cardiac monitoring, especially if they have any cardiac history, such as atrial fibrillation, making sure that we have multiple IV lines in place as we're going to be using them. Blood pressure management is also important in the patient with the ischemic stroke. We need to use medications to lower the patient's blood pressure only if the blood pressure is markedly increased. In the patient not receiving fibrinolytic treatment, we would want to make sure that we treat any systolic greater than 220 or a diastolic greater than 110. If a patient has received fibrinolytic treatment for 24 hours following the fibrinolytic treatment, we want to make sure that we don't let them have a systolic greater than 180 or a diastolic greater than 105. Although low blood pressure immediately following a stroke is actually uncommon, if the patient does present with hypotension or hypovolemia, those factors should be corrected immediately if present. A physician may initiate aspirin at 325 milligrams a day within about 24 to 48 hours after the onset of an ischemic stroke. However, the use of anticoagulants in the emergency phase is generally contraindicated with an ischemic stroke because there is a risk for intracranial hemorrhage. By discharge, the patient will generally be placed on some type of platelet inhibitor, such as aspirin, ticlopidine, clopidogrel, or dipyridamole. As discussed in part 1, when I was mentioning patients with TIAs, patients with atrial fibrillation would be placed on some type of oral anticoagulant such as warfarin, rivaroxaban, or dabigatran. By discharge, these patients should also be placed on some type of antilipemic, such as the one of the statins that we discussed in part 1. Fibrinolytic treatment is also going to be an option for the patient with an ischemic stroke. However, it does need to be determined if they meet the criteria for fibrinolytic treatment, and there is a checklist that has to be covered in determining whether or not an individual with an ischemic stroke is a candidate for fibrinolytics, and we'll talk about that here on the next slide. Another recommendation in the treatment of the ischemic stroke is that the patient is treated at a stroke center. So if they're not being seen at a stroke certified facility, they should be transferred to the nearest stroke certified or the nearest certified stroke center as soon as possible. The reason is that about 25% of all patients will worsen in the first 24 to 48 hours. Because of this, the American Heart Association recommends that acute care facilities have what is known as stroke teams in place. A stroke team consists of an RN, a neurologist, a radiologist, and a CT technician, all specifically trained in the treatment of patients with strokes. When it comes to the administration of the fibrinolytics to the patients with ischemic strokes, they must be screened before the TPA can be administered. TPA is the fibrinolytic of choice to be administered to patients with ischemic strokes. So screening for the administration of TPA includes first that non-contrast CT, as mentioned in the diagnostics, or an MRI. One has to be done to rule out that this is not a hemorrhagic stroke. There also needs to be some blood testing done to check for any potential coagulation disorders. They need to be screened for any recent history of gastrointestinal bleeding, any recent history of a stroke or head trauma within the last 3 months, or any major surgery within the last 14 days. If any of these situations are present, these would be criteria used to actually exclude a patient as being a candidate for TPA administration. So first, we'll look at what is the criteria for inclusion, meaning what criteria must be met in order for them to be eligible for TPA administration. One, they must be 18 years of age or older. They must have that diagnosis of the ischemic stroke with the neurologic deficit. And again, that goes back to utilizing that non-contrast CT or MRI to give us the confirmation that what we do have is in fact an ischemic stroke and not a hemorrhagic stroke. We also, the current recommendation on behalf of the American Heart Association and the American Stroke Association is that they are treated within 4.5 hours of onset of the symptoms. So this is why timing is of the essence in getting a patient who is experiencing symptoms of a stroke to an appropriate facility as fast as possible. Patients who are treated with a drug such as TPA within 4.5 hours of onset of their symptoms have a greater chance of recovering without major disability. The criteria for TPA timeline administration has been increased in just the last couple of years to the 4.5 hour window. Prior to that, it was only a 3-hour window. There are some studies out there that's looking at extending this window even a little bit longer to 6 and potentially even 9 hours following the onset of the symptoms, but the current recommendation by the associations that we consider to have provide the best evidence-based practice is that 4.5 hours is the current recommendation on their behalf. If a patient meets this inclusion criteria and does not have some of the exclusion criteria that we mentioned, A neurovascular specialist would actually insert a thin catheter into an artery, usually the femoral artery, and they would guide that catheter up to the area of the clot with the use of an angiogram. They would then administer the TPA through the catheter, immediately targeting the clot. Less TPA is needed when it is delivered directly at the clot, and this is important because it can reduce the possibility of intracranial hemorrhage. It's important to make a note here that a fibrinolytic works very differently than an antiplatelet or an anticoagulant. You've learned a lot about antiplatelets and anticoagulants in your pharmacology courses and in your previous courses, and we know that those are drugs that prevent the formation of a clot, or they prevent a clot from getting any bigger. However, those drugs do not possess the ability to actually break up an active clot. A fibrinolytic is a classification of a drug that does possess the ability to actively break up a clot. Let's go ahead and take a look at a couple of the other categories here. We have what we call exclusion criteria, and then we have what we call relative contraindications for the fibrinolytic checklist. Things that would exclude an individual from being eligible for fibrinolytic treatment would be if they have any evidence or any history of an intracranial hemorrhage, if there's any suggestion of a bleed, even if the CAT scan is negative, if there's any symptoms that suggest they might have some type of subarachnoid bleed, that would exclude them from being eligible for this. Any evidence of multilobar infarcts that are in more than a third of the cerebral hemisphere, so those extremely large strokes. If the patient's experiencing uncontrolled hypertension with measurements of systolics greater than 185 or diastolics greater than 110, and anybody with any active internal bleeding. Again, this is a drug that is geared at breaking up an active clot, and therefore it would be very dangerous to a patient who has any type of history of abnormal bleeding or any current bleeding. Also, anybody with uncontrolled hypertension is going to be at great risk for the potential to rupture a vessel, and that bleeding would be difficult, if not impossible, to control if they were on fibrinolytic treatment at the time. Our relative contraindications are a list of criteria that we look at and say, well, this really isn't a good idea, but what we do with the relative contraindications is the physician would need to determine if the benefit of the fibrinolytic outweighs the risk of the contraindication listed here at the bottom. So these are going to be our patients with any kind of gastrointestinal or urinary tract hemorrhage within the past 3 weeks, anybody with a post-myocardial infarction pericarditis that developed, anybody with a recent MI in the last 3 months, platelet counts that are less than 100,000, or anybody who's currently on anticoagulant therapy, with an INR of 1.7 or greater. So this last set of contraindications here aren't necessarily reasons to exclude a patient, but they would be reasons for the physician to take a strong consideration as to, again, whether or not those benefits of the medication, the fibrinolytic, would outweigh the risk that the patient with any of those criteria has. As far as the RN's role with TPA administration, if we are expecting a patient to be a candidate for TPA, our responsibilities are going to be that they are going to need a catheter in place, they're going to need a nasogastric tube in place, and they're going to absolutely need multiple IVs. As mentioned on the previous slide, at least 3 IV lines is generally recommended for the stroke patient anyways. So those are things that must be in place before the TPA administration begins, and those would be responsibilities of the RN. During infusion of the drug, the RN would be responsible for monitoring the patient's vital signs and their neurologic status, assessing for any improvement or potential deterioration that could be present if, say, intracerebral hemorrhage were to develop. The RN would also want to perform focused neuro checks and be monitoring those vital signs similar to post-op vital signs, usually for like every 30 minutes, then every hour, and following just the ICU standard of care for vital sign assessment. Control of the blood pressure is critical during treatment and for at least 24 hours following. So the RN is going to have PRN orders for blood pressure management. So again, that blood pressure has to be strictly monitored, and those orders need to be carried out if the blood pressure exceeds the parameters set for the patient. Any IV lines or tube insertions, as I mentioned at the beginning there, like the catheter tube, the nasogastric tube, the multiple IVs, we want all of that in place before we start the TPA, because we do not want, if at all possible, we want to avoid insertion of any NG tubes. We want to avoid any blood draws, any IM injections, any IV line changes for at least 24 hours post-infusion, if at all possible. Again, minimizing the risks for additional bleeding that could occur as a result of the medication administration. We want to try to diligently maintain those IV lines that are already in place. Again, restarting them only if absolutely necessary. If any sites have been changed, the nurse would additionally need to observe any previous insertion sites very carefully for bleeding at the site. It could be necessary to apply pressure over those old IV insertion sites or old blood draw sites, as they are at risk for even rebleeding once the fibrinolytic treatment has begun. The nurse would want to observe for any signs of an adverse drug reaction to fibrinolytic. The primary adverse drug reaction, again, here would be any type of abnormal bleeding. So you would want to report any bleeding from the gums, any abnormal ecchymosis or petechiae, if the patient's reporting abdominal or flank pain, if they're experiencing any hemoptysis or hematoemesis. These could all be indications of basically an adverse drug reaction from the fibrinolytic. So any type of abnormal bleeding, you would want to report promptly to the physician. One last observation that the RN should make is to monitor the extremities for color, temperature, and sensation, just to ensure that adequate circulation is maintained following the drug administration. Angioplasty and stenting is also a possible line of treatment for the patient with an ischemic stroke. One way that this is done is through the Mercy Retriever. The Mercy Retriever is a device that is used for mechanical clot extraction in a cerebral artery. If this procedure can be done within 8 hours of the stroke onset, it produces a almost 50% vessel reopening, and that results in both lower morbidity and mortality rates in ischemic stroke patients. It can only be used on an ischemic stroke. It does carry risks of puncturing the blood vessel, and obviously then we would, have what was an ischemic stroke now potentially progress even into a hemorrhagic stroke. As far as angioplasty and stenting goes, that's a process that works very similar to angioplasty and stenting on the coronary vessels. Here we're just talking about doing it to the cerebral vessels instead. When it comes to the treatment of a hemorrhagic stroke, our emergency focus is going to be on controlling bleeding and reducing the pressure in the brain. So our goals of treatment with this patient is going to be to try to maintain an appropriate blood pressure, to prevent seizure activity. So they'll likely be getting medications for both of those. Once we can get the bleeding stopped, treatment would involve supportive care, giving the body time to absorb the blood. Healing is similar in a hemorrhagic stroke, if possible, to what happens as a bad bruise goes away. However, if the area of bleeding is very large, the patient may be a candidate for surgery to remove the blood and relieve that pressure on the brain. In addition to evacuation of the bleeding, in surgical terms, they may also need to clamp an aneurysm to prevent any further bleeding as well from the ruptured vessel. Overall goals for the patient with the hemorrhagic stroke: once the bleeding is under control, we're going to focus then our efforts at maintaining cerebral perfusion pressure and then monitoring for and treating any signs and symptoms of increased intracranial pressure. Collaborative care for the stroke patient includes assessment for the impact of the stroke on the various body systems. In regards to the neurologic system, as discussed already, we would be monitoring the NIH stroke scale regularly, watching for any trends in scoring. We would also be watching for and treating any signs of increasing intracranial pressure. Cardiac system assessments will focus on maintaining homeostasis and monitoring and treating any blood pressure abnormalities, as well as monitoring for any abnormal electrical activity of the heart. Bedside monitors or telemetry will be included as part of the treatment plan for the stroke patient. Not only do we need to watch for hypertension very closely with our stroke patient, but we'll also need to monitor for orthostatic hypotension as we get the patient up and ambulate them for the first time. Additionally, after a stroke, a patient is at risk for a venous thromboembolism. So additional measures to prevent VTEs, including positioning to minimize the effects of dependent edema, the use of elastic compression stockings or support hose, even possibly for a period of time, the use of SCDs in immobile patients may be necessary to minimize the risk for VTE. The advanced age and immobility of the stroke patient generally increases the risks for developing atelectasis and pneumonia. So those are going to be some considerations we're going to take in regards to our assessment of the respiratory system. We want to carefully monitor for the effectiveness of their respirations. Again, making sure that we do maintain an SpO2 at equal to or greater than 94%. Aspiration is also a risk for the stroke patient. So we do want to watch for any signs or symptoms of aspiration once oral feeding has been allowed to resume. However, it is important to note that any patient with a stroke must be effectively screened for their ability to swallow by a speech therapist before oral feedings can resume. So they have to be kept NPO until any type of dysphagia has been ruled out. In regards to the musculoskeletal system, our goal certainly here is going to be to maintain optimal functioning. If the patient's able to understand communication, we want to teach them active range of motion exercises for any voluntary movement that they are capable of doing in the affected extremity. For patients with hemiplegia, passive range of motion exercises should be done several times a day. The patient should also be working with physical therapy, occupational therapy, and speech therapy early on and often throughout their recovery phase. And again, we want to either they need to be performing the active range of motion exercises or we need to be doing passive range of motion for them on a routine basis. In regards to the integumentary system, turning and repositioning every 2 hours will be necessary on patients who are unable to move themselves. We want to make sure that we do assess the skin routinely, perform good hygiene, watch for any problems with skin integrity. We want to get them mobilized as early as possible, again, with the assistance of physical therapy and occupational therapy. In regards to the gastrointestinal system, we'll be monitoring their bowel movements carefully, treating any abnormalities early on. A bowel retraining program might be something that is necessary depending on any bowel issues that they may have. Bladder issues can also be a problem for new stroke patients. It's not uncommon for them to experience some incontinence, but over time, this is an issue that can correct on its own. As far as their nutrition, once they are able to resume oral feedings, it must be done carefully. In the beginning, oral feedings must be initiated by speech therapy, where they will watch for any problems with an impaired gag reflex. Once speech therapy has cleared them to resume oral feedings, the first few after that should be done by the nurse, and only once it's been determined that the patient is safely able to eat without any potential for aspiration can the unlicensed assistive personnel step in and assist with feeding, or the patient then resume feeding themselves. They may need special utensils to promote self-feeding, and that's something that occupational therapy will evaluate for and provide to the patient if needed. When it comes to communication, some important points to remember are that we're going to need to allow a little extra time for the patient to comprehend what they're being told. We may have to allow some additional time for them to be able to answer questions or tell us what it is that they need. Some communication techniques that are useful with the stroke patient are to use simple, short sentences, to use visual cues, and of course, be patient and persistent with them. Don't give up on them when it comes to communication. In regards to health promotion with the stroke patient, here we're going to look at actions that can be taken to prevent the risks of strokes, either through primary prevention or through secondary prevention. Primary prevention is going to be a priority when it comes to decreasing the morbidity and the mortality risk from the stroke itself. The overall goals of stroke prevention include health promotion for a healthy lifestyle and management of any modifiable risk factors in order to prevent a stroke. Secondary prevention is going to be aimed at the management of other diseases, which ultimately increase the risks for strokes. Patients with known risk factors such as diabetes, hypertension, obesity, high cholesterol levels, or cardiac dysfunction require close ongoing monitoring and management of these conditions in order to prevent the likelihood of a stroke from occurring.